get started because we have a great speaker today, and on behalf of the Land and Lamb Committee, I want to welcome all of y'all. This ministry has impacted so many folks in our congregation because mental wellness is something we all deal with. It's just like our health. And I'm personally very proud of our congregation and our church as taking this topic on and really delving into it and normalizing the conversation about our emotional well-being. Today, we have Lauren Monroe, Kim McCullum, and Marina to thank for bringing us our wonderful speaker. Our speaker is Dr. Ben Hunter, who is the Chief Medical Officer at Skyland Trail. I'm sure most of you have heard about that. We're so lucky in Atlanta to have this wonderful nonprofit mental health treatment organization. Dr. Hunter provides leadership and oversight for all clinical services, research, and outcomes analysis and reporting. Also, Dr. Hunter completed his medical training at Emory University School of Medicine, followed by a psychiatric residency at the University of Pennsylvania, where he served as a chief resident during his final year. Dr. Hunter also completed organizational psychiatry with Group for Advancement of Psychiatry. He is an elected fellow of the American Psychiatric Association, treasurer, and the 2024 president-elect of the Georgia Psychiatric Physicians Association, and a member of numerous state and national level committees aimed at improving access to psychiatric care. You're very busy. When you have time to do anything else. And also, he brings with him today Molly Mercer-Dedman, who is the Director of Education. Both of these well-qualified people will be available after the talk to answer questions if any of y'all should have one. And one thing that isn't one land, I promised Jamie Jenkins that I would pass this around because he and Bill are going to lead another one of their famous fabulous trips, and this one is to England. So I'll pass that around, and I think Lauren needs this up real quick.
I was just going to say I passed out some forms that are feedback forms that if you could please complete those after Dr. Hunter speaks. It also has an opportunity to suggest future talks. And the One Land Project really uses your feedback for future programming. So please take the time to do that. And you can give them to me or you can leave them on your chair and we'll collect them at the end. Okay, thank you.
Thank you. How's my volume? Everyone good? Okay, great. Thank you so much for having us today. I think, as we mentioned in the bio, outreach is such an important part of mental health treatment. In the United States right now, worldwide, awareness is growing. I think one of the unintended, few positive impacts of COVID has been that we all are a little more aware of mental health and how it affects so many people in the population, directly and indirectly. It's probably going to be rare that anyone in the audience hasn't had their life touched in some way or another by depression. So again, you guys being out here today and allowing us to speak and kind of be out in the community is really what helps us spread the word, just like you all do in church. So thanks so much for having us. Please feel free to ask questions in the middle of this. Raise your hand. Would love to hear feedback about this too. I actually made this for you guys. This is a new talk that hopefully we'll get to give in a few other places too, but appreciate the opportunity to kind of to have a reason to make a talk about depression. We talk a lot in a medical context and less in the community about depression. So excited to do this for you all today. We treat quite a bit of it at Skyland Trail. The only thing I'll mention is that I do speak for one antidepressant medication company called Axon Therapeutics. We will not talk about that medication at all today, but suffice to say I do treat a lot of depression and think a lot about depression. So we'll look at, and again, I realize maybe the font might be a little hard to read. Can people in the back actually see this? Okay, all right. We'll use a medical model, and I think it's really important to think about depression and other mental health issues as medical issues. We're still fighting stigma around mental health conditions. We're fighting an old model where we thought about people with mental health issues as struggling, not necessarily with a biological medical illness, but with a loss of faith or character issues or effort issues. It's sort of like if you just work harder, you'll be able to move through this. Everybody feels sad. Why don't we just kind of pick ourselves up by our bootstraps? This is a medical condition that we treat with scientifically evidence-based treatments. We can study it epidemiologically, and we'll talk about a few different medical versions of what people will view as depression or depressive symptoms today. talk a little bit about diagnosis and treatment, talk about some warning signs, and hopefully we'll walk away today with, again, a good picture of a few different types of depression, kind of what might trigger you to want to seek mental health help and treatment. And then, again, just talk about how you can support these people as families and church support system too. So, medicine, we go to the doctor, we get prescribed Prozac, we go on our way. This is not the model we have at Skyland Trail. I think for most of us, this is not the way we want to think about treating any medical condition, but certainly not mental health conditions. For many people who come in with their first episode of anxiety or depression, they start to realize that it's impacting their lives in a negative way. The first conversation we should have is about behavioral lifestyle interventions that can help mitigate symptoms, help people be healthier overall. The first place we always start at Skyland Trail, and again, we have people with usually a little bit more severe illness who will need medications and other more advanced therapies, but even in that setting, we talk about sleep, we talk about nutrition, we talk about exercise, we talk about socializing and kind of the people that you will spend your time around, and we'll talk about things like alcohol reduction, drug use discontinuation, things like that. These are the biggest, kind of easiest levers to pull with any medical condition. And for many people, again, especially who come in with mild to moderate symptoms, you can resolve either fully or at least partially the symptoms that they're experiencing just by hitting those targets. Again, they're not, not everybody can pull all those levers at once. I've got a patient right now who's a new parent, and it's not gonna happen, right? But he's at least thinking about it. That's the key. Take your kid for a walk rather than playing, in the den. Again, the other thing to mention though, lots of holistic medicine approaches out there, whether it's in popular media, social media, commercials. You're seeing a lot of supplements and a lot of different, kind of miracle cures being pitched. When people are experiencing moderate to severe symptoms especially, so when their lives are being significantly impacted by depression or anxiety or any severe mental illness, that is not a standalone treatment. So unfortunately what we will see is many people come in for treatment further down the line, and they've gone a number of months, sometimes years, without trying kind of first-line evidence-based medical treatments. And unfortunately, that becomes much harder to treat at that point, and oftentimes there's more disability, more dysfunction over time. And one of the most important things we'll mention today is that there is a bidirectional kind of chicken and egg, both directions effect between general and psychiatric health. So we'll talk about physical and mental health as if they're two different things, and that's a false distinction to make. But suffice to say that being mentally healthy requires someone to also pay attention to their physical health. Being physically healthy also requires someone to pay attention to their mental health. They're inextricable. Again, if you're missing on either one of the two sides, it's really hard to keep well in the other side too. And this is going to be hard to read. It's not meant to be necessarily read in detail, but just a model that was proposed by actually one of our Emory colleagues, Andy Miller, back in 2013. He was publishing quite a bit in scientific journals around that time and really brought this to the forefront probably as much as any other researcher. But the idea that the immune system and inflammation in the body directly affects the way the brain functions as well. So, again, the point here being that whenever anyone is undergoing a physical health issue, so a COVID infection, a joint injury, autoimmune disease, chronic diabetes is not well managed, the body will respond to that by activating the immune system and circulating inflammatory factors. So you'll see all these listed molecules up here: interferons, interleukins, tumor necrosis factor. These are all the things that circulate through our bloodstream to help remedy infections or illnesses, injuries. And when we think about what happens when you have an infection, for example, let's imagine a cut that gets infected on the skin. You'll see redness, you'll feel warmth, you'll start to have pain at the site, you might have swelling. All of these things are mediated by the molecules that are circulating through your bloodstream. And the unfortunate thing is we do not have a highly targeted way of addressing issues like that. So if you have a COVID infection in your lungs, unfortunately, we can't send these factors just to the lungs. They just circulate widely through the bloodstream. And what's unfortunate is that other organs, other tissues that are not meant to be affected by the inflammatory response, unfortunately do kind of receive those factors as well. Not a problem if you have a short-term issue. So again, if you injure your knee and you send a lot of these factors to your whole body and your knee eventually heals up and you move on, there won't be much of a long-term effect from having inflammation in your whole body. Unfortunately, what we're seeing nowadays is whether it's sort of this long COVID syndrome where you have this chronic inflammatory response over time, or it's, again, diabetes, it's poorly controlled, so you have sort of that blood glucose dysregulation and you just sort of chronically have inflammation for years and years at a time, is it really starts to actually negatively impact other organs in more of a kind of chronic, permanent way. So again, we think about this as a key factor in patients who come in with mental health issues. We always look at their physical health, kind of see if there's anything we need to work on where we can kind of reduce that total body inflammation level. Because what we know is that if someone is struggling with, again, an autoimmune condition like psoriasis, for example, that's not well managed, unfortunately, it will bathe their brain in these inflammatory factors for years at a time, which increases the severity and frequency of things like depressive episodes, anxiety, sort of exacerbations, bipolar, manic episodes, things like that. It's also operating the other direction too. So if we have somebody who has chronic depression that's not well treated, unfortunately that will make it harder to manage diabetes or an autoimmune condition or to recover from an injury to a bone or joint. So again, critical that when anyone is evaluated for a mental health issue, they also get their physical health evaluated. And that includes typically for us a physical exam, kind of an annual wellness exam, lab work, and any other sort of exams that we need to do to make sure that we understand how to manage chronic physical health issues too. So depression, I mean, no surprise here. This is the leading cause of disability worldwide of all medical conditions. In terms of overall disease burden, I mean, fourth among, this is including heart disease, cancer, and all the things we think about, fourth leading cause of disease burden. About 6% of Americans in any given year, 5 to 7% will have a major depressive episode, so at least 2 weeks of significant depressive symptoms. 21 million Americans diagnosed at any given time. And again, we think about suicide as really the most severe and frightening side effect of depression or effect of depression. 700,000 people a year. In America, close to 50,000 when we last measured. It's kind of growing. It luckily has flattened out a little bit in recent years, but that rate of depression is higher than deaths by breast cancer. It's higher than deaths by motor vehicle accident, which I think we all think about those things as being very significant in terms of the number of people that are affected. Suicide is higher by about 5,000 or so than each of those two conditions. And again, it will touch all of us in one way or another. So with that, I thought it might be a little more enjoyable to talk through a few kind of cases or example people who we can kind of think through. They're all going to have depressive symptoms, but we'll figure out sort of what specific version of depression they have. So here's Mary, 52, has had depression since her 20s. Realized it was an issue because she had to take time off of college, which, by the way, is smart. Any of you have college-age kids, if they are struggling with their grades and it is because of depression, oftentimes taking a break and getting their mental health under control is really a great first step to get them back on track. Colleges are used to dealing with this all the time. They find ways to get their kids back online. The worst thing a college can have happen is that their kid doesn't graduate. You guys know what the U.S. News and World Report rankings do. They measure graduation rates. They want to work to get your kids back in. She was feeling kind of sad, kind of that was her depressive symptom that she kind of made her think about depression primarily, but also felt physically sluggish, felt like her brain wasn't working quite the way it had before, just wasn't enjoying things the way she typically would. Important to note that her grandfather died by suicide, so she, like many people who have depression, experienced thoughts about suicide and was particularly worried because she had lost a family member, and she knew how stigmatized that was in her family. Over time, again, kind of intermittent episodes, less severe, shorter in duration once she started medications and started doing psychotherapy. And again, just important factors, boxes to check. She doesn't drink excessively and doesn't use drugs. So this is classic major depressive disorder, right? So we're thinking about depression again. There are at least 5 or 10 different types you can look at and kind of different causes for depression. But the most prominent, the most common that we'll see will be major depressive disorder in a clinical setting. So this is what we typically call clinical depression. People say they have depression, this is usually what they mean. Typically presents around the late teens, early 20s for their first episode for most people. A little bit higher in women than men, but relatively close. And again, the classic and hallmark major depressive disorder is relapsing and remitting episodes over time. So we don't have a great cure for depression. What we try to do is treat depression so that, like this case here, you have someone who has fewer episodes, shorter in duration, and less severe. And for many people, they will go years at a time without having depression. People who have mild depression, they may never actually say that they have a depressive episode again once they've been treated well. And when we think about depression and when it becomes clinically significant, if it is impacting functioning for at least 2 weeks, meaning you are not able to be there for your family, or you're having trouble working, or you're just feeling off to a point that you can't socialize, and you're feeling distressed about that, if that goes on for 2 weeks or more, we would call that a major depressive episode. The symptoms that we use to diagnose are on the right. One important checkpoint to hit again is that we don't have a medical condition causing it. So again, there are many reasons that people will have, again, medical issues that will cause depression. Hypothyroidism is a classic one. So for example, when anybody comes in with a depressive episode, first thing we do is make sure we've had thyroid labs recently. Hypothyroidism looks almost exactly like depression with a few other differences. Substance use issues also will make people look depressed, so we rule that out first too. Also want to rule it out even if it is depression, we want to make sure that we're not making it harder to treat, making it worse by substance use. And then treatment, again, our first line, for anybody who's mild to moderate, again, we can think about behavioral interventions like the one we mentioned, psychotherapy, so the classic kind of talk therapy. We have several evidence-based versions. When I say evidence-based, I mean that we've studied them scientifically and shown their benefit and shown their risk and weighed those out to be disproportionately beneficial. And then medications, so these are your classic, Prozac, Zoloft, Lexapro, SSRIs, and SNRIs as first line. Additionally, what's exciting in the 2020s with psychiatry, in particular for depression, is that we're starting to have more additional options. So at Skyland Trail, we do a lot of TMS, which stands for transcranial magnetic stimulation. So that is direct stimulation of the brain using a magnetic pulse. It is not nearly as invasive as it sounds. We have patients come in and sit in basically a dental chair. We connect a magnet essentially right to the edge of their scalp, turn it on, and then over the course of a number of sessions, we actually can treat depression very effectively. Response and remission rates are very high for that treatment, and insurance now covers it very well because they've seen how effective it is for patients who are otherwise struggling quite a bit. Electroconvulsive therapy, one thing to mention, I always mention this in every depression talk. Electroconvulsive therapy, or what we used to call shock therapy, still the gold standard treatment for depression that is severe and does not respond to medication. So probably a lot of people in this room have seen Cuckoo's Nest. It does not look like that anymore. I got asked at a talk once about TMS. I always talk about ECT again. Somebody said, what's the biggest advance in electroconvulsive therapy treatment in the last 20 years? Have there been any changes? I'm like, there's been one big change, is that the new generation hasn't seen Cuckoo's Nest. That's the biggest thing. But yeah, it is a very humane, if we were to be able to show a video of ECT, I think everybody would be shocked at how kind of humane it looks. It is a life-saving treatment for many people. One of the great things about electroconvulsive therapy is it is cross-diagnostic, so it treats depression, it treats bipolar depression as well, and mania. It can also treat psychosis and schizophrenia. It also is shown to reduce suicide rates. So again, if your docs are recommending ECT for anyone you love, just remember one more person said ECT is a great life-saving treatment. We now do deep brain stimulation too, not at Skyland Trail, but at Emory. They will actually implant electrodes in people's brains and treat things classically like Parkinson's disease. They could do really effective treatment where they, again, stimulate an area continuously in the brain to reduce Parkinson's symptoms. But now we can treat things like OCD, depression, and other disorders using deep brain electrodes as well. Not a first-line treatment clearly, but again, very safe. And then things like ketamine. So you've probably all seen at least one news article about psychedelic medications coming out too. So using things like MDMA or ecstasy or psilocybin and mushrooms to treat depression in clinical and other anxiety conditions as well, in clinically dosed, in a clinically dosed way. I think we're all very hopeful about those things, also very cautious because of obviously the abuse potential. We tried this with LSD in the 60s and it didn't go great. We're doing it differently this time. Learn from your mistakes. So with major depression, prognosis is really, really positive. And the sooner we treat it and the more effectively we treat it, the better. We always target remission as our goal for treating any mental health condition. So what you'll see often is, and especially at Skyland Trail, is a lot of people come in, after years of struggling and feeling poorly, and they'll say, I've kind of had periods where I do a little better, and maybe I'm like 50 or 70% better, but I've never really felt like I'm all the way better. And sometimes we can get away because people will go back to functioning and they can, like, you know, get the kids to school and go to work if they're 50% better. But in thinking about that medical model, if we don't totally sort of knock down that inflammatory response by getting someone to the point where they're sort of well, and kind of all the way well, as we describe it, you know, using scales and other evidence-based methods, they're still going to be undergoing all those processes that will continue to make that issue and other issues worse over time. So we want to treat to the point where symptoms are basically gone. It doesn't necessarily mean to zero, but it means pretty close to zero. And if we stop short of that, again, we are leaving people prone to more depression and other issues in the future. Again, in some people, especially mild cases of depression, psychotherapy can be as, and again, we're talking about talk therapy there, can be as effective as medication. We think about cognitive behavioral therapy, so a lot of ads for CBT you'll see, or DBT, which is a derivative of CBT. Again, very evidence-based, studied extensively. Psychodynamic therapy, which is more of the classic kind of sit in a chair and talk to someone in a little more freestyle way. A lot of psychologists and psychiatrists will practice psychodynamic therapy. Other things to note though, patients who have had 2 or more depressive episodes in their life will probably need to be on medication kind of indefinitely. And that of course, you know, the origin matters. Again, if one of them was caused by another one of our depression causes today, that sort of wouldn't count. But when we see someone with biological depression and it has happened multiple times, what we'll often counsel them is we will be able to reduce your dose over time most likely, but we will probably never take you completely off medications because we don't want you to relapse into depression. This doesn't make everyone happy to hear. I think a lot of folks, especially because it's really hard to think about having to deal with one more chronic medical issue and they kind of don't want to be defined by their depression and feel like they have to take medications forever. We have this discussion where, again, we think about treating other issues. If someone has diabetes, type 1 diabetes, for example, they're going to want to take insulin forever, and they wouldn't question themselves for it. This really is not fundamentally different. Again, we use higher tech therapies for people that have been struggling to achieve remission over time. And again, we have some other interventions like ketamine that can really help cut into depression, especially on the severe side. Not my time here. One thing that's incredibly important to rule out whenever we think about depression is bipolar disorder. So bipolar disorder is one of the most misunderstood diagnoses in medicine right now. We probably undiagnose 3 or 4 cases of bipolar disorder for every one we diagnose in Skyland Trail. But suffice to say that when someone has true bipolar disorder, it's a manic episode is a medical emergency. It's something that should be treated emergently. Bipolar disorder is not mood swings. It's not day-to-day fluctuations in anger and, you know, happy 1 minute, angry the next minute. It's 4 to 7 days plus of significant personality changes. So you will see kind of like a different person. I mean, it's almost cartoonish when you see somebody with hypomania or mania, which are again the defining elements of bipolar disorder. They are speaking fast, they are making impulsive decisions, they have 1,000 different thoughts going on and 1,000 different projects, they're not sleeping. It's this constellation of symptoms that will go on for, you know, again, 4 to 7 days plus, and then it will relapse completely, and it will go away for months at a time. It's not the day-to-day, well, you know, I've always had trouble controlling my mood. We'll talk a little more about what that could be in a second. But we want to make sure, again, if you miss bipolar disorder and you treat with antidepressant medications, you can make that person more likely to have more mania. So you got to be really careful about that. That's why it's important to go, especially if you've had severe depression, to a psychiatrist rather than just a PCP. Lots of other disorders will share symptoms with bipolar disorder. And again, if you're not sure, just a psychiatrist should be the person to go to. So case number 2. This is a 70-year-old man, no prior mental health concerns, significant depression for 4 months in the setting of losing his wife. So this is a really classic situation. Kids started to notice, you know, dad's off, losing weight, kind of just isolating, not doing a whole lot of the things he previously done to keep himself well and happy. Started to meet with a therapist at the kid's recommendation. Again, went with the behavioral interventions because again, this is mild. It's his first time having an episode. He's 70 years old. Probably not major depressive disorder, right? You don't get your first depressive episode typically when you're 70. Rarely. But really encouraged him to keep doing the things he used to do, even though it didn't feel quite the same. it's amazing how the fake it till you make it sort of approach can really work well for mental health issues. And then went to a psychiatrist and saw a psychiatrist and received an antidepressant medication, started doing better. Still misses his wife, but, and these are all based on people we've treated in the past, by the way. I kept them out of Atlanta just to make sure, but names are obviously changed. But I remember this patient, he used to say, I still miss her every day, but, I'm able to move on and do what I need to do for my kids and for my life. So, one of the things, especially, and probably what you guys will experience among, your congregation, you'll have people who really will struggle with grief. And, bereavement, again, being the situation where we've lost someone, and grief being the response to that, there's no right way to grieve. There's, length of time, the way it's experienced will vary between people, between cultures. Prolonged grief disorder is what we will define as atypical based on length of time or severity of the symptoms, especially when they start to interfere with functioning in a prolonged way. So often look very much like depression, but you'll hear a strong thematic kind of attachment to the loss, and it's again typically coming up at a time in life when again it might be a little too late to have the first depressive episode. One thing that can be very distressing to people with grief, but I kind of want to normalize here, having hallucinations of a loved one's voice, which sounds scary if, mom or dad says they're, kind of hearing their partner's voice, is actually quite common. So, it's something we don't treat that like schizophrenia. It's not a psychotic disorder. It is a way that the brain copes. Things you want to watch out for. This is where we really want to make sure we don't start to move into alcohol use or other drug use as a way of mitigating symptoms. Therapy, and especially group therapy and support groups, can be really effective, again, being in a community like this. Antidepressant medications can reduce the length and severity of symptoms. So again, these are not people who will typically have to be on antidepressants indefinitely, but if someone's really struggling, these can really get somebody back on track a little more quickly. Suicide screening still, even though this, it feels like, oh, this is obviously related to something very, tangible, and it's something that we will move through, suicide rates are still high, because again, a lot of people feel that grief of, what's my life gonna be like now, or how do I move on without this person? Parents who've lost kids, especially, you really want to be careful, especially if substance use is in the picture too. Anything that makes people a little more impulsive, you'll really worry about suicide. So again, whether it's alcohol, whether it's benzodiazepine medications like Xanax and Klonopin and those things, Valium that we prescribe sometimes for anxiety, not so much anymore. Lowering inhibition raises suicide rates. So again, anybody who's struggling or has people around them who are struggling with thoughts about suicide, you really want to remove anything that's going to lower the barrier to dying by suicide. So you want guns out of the house, you want alcohol use at a minimum, you don't want people to be out of their normal state of mind. Case 3, so very common Skyland Trail case here. 22-year-old woman, history of depression, basically says she's been depressed ever since her mom died at age 4. Reports that her symptoms have never remitted for more than a week or two at a time. Stressful times seem to make her symptoms worse. Says she's depressed almost every day for her entire life since that point. Can bounce back, sort of like whenever something positive happens, she's relatively, resilient in that way. But again, these kind of mood swings have led her to be diagnosed with bipolar II disorder when she was a teen. Again, we'll come back to why that's not the case, but experiencing thoughts about suicide at least weekly often kind of starts conversations with parents, friends, kind of in places where it gets her into a little bit of trouble in the sense that it makes for awkward conversations, people that don't really, want to engage around suicidal thinking, friends especially, and kind of romantic partners. Did have a suicide attempt at one point after a fight with boyfriend, kind of wrote the note, took the pills, then called him to tell him what she'd just done, and obviously massive guilt trip there. Been hospitalized 6 times for depression, suicidal thinking. Again, no treatment has worked other than using marijuana so far. Struggling to do her schoolwork and is basically failing out of college at this point. Again, she's in treatment because her parents basically said they'd cut her off. Her father, I should say, said he would cut her off. Mom is gone, unfortunately. but continues to use marijuana and sort of has these cutting behaviors on wrists and thighs. So again, one of the more prevalent issues at Skyland Trail and other residential treatment programs, what we're seeing more, unfortunately, in teens and young adults, especially, borderline personality disorder. So this is a little different than depression in that it does not kind of wax and wane over time. Personality disorders, by definition, are consistent across the lifespan. They will not kind of come and go. I think people will change in terms of their level of functioning at any given time. They might function better at certain points, but these, by definition, are persistent. Again, the symptoms you'll see will be kind of poor identity, sense of self, a lot of insecurity, in interpersonal relationships, kind of chaotic relationships, lots of breakups, and kind of kind of frantic romantic efforts are very common. Difficulty with boundaries with other people and frankly with themselves as well internally. You have a fundamental kind of issue with attachment here and identity development. So these people are often really trying to create an identity for themselves, often by using other people to modulate that. Chronic suicidal thinking and self-injury are kind of the hallmark pathognomonic symptoms here. So again, when we see someone who has done lots of self-injury, sort of cutting or burning or other things like that to themselves, usually it's borderline personality disorder. Might look manic or even psychotic sometimes, so they'll talk about hallucinating or kind of being out of their body or kind of feeling like reality's not kind of real. Again, not schizophrenia, but something that we do see in borderline personality, and often associated with trauma and with, unfortunately, upbringings that feature households where there's lots of interpersonal chaos as well. So you'll see lots of parents who have either borderline personality disorder or narcissistic personality disorder will generate some kids with borderline symptoms. Kind of a nature and nurture effect here. For borderline personality, we target the symptoms with our treatment. So there is no evidence-based treatment specifically for borderline personality. There's no medication that's FDA approved for borderline personality. We'll usually go to the antidepressants and mood stabilizers to help with those symptoms that we've discussed. The one evidence-based treatment that we lean on very heavily is dialectical behavioral therapy. So this is DBT, if anyone's heard it, very popular, probably over-applied, frankly, but at some level, DBT is about coping, safety, and ensuring that people can kind of move through thoughts about suicide and self-harm so that they can actually work on just kind of resolving what's underneath that. Oftentimes people with borderline personality and personality disorders are so frantically ill that they can never really address what's underneath because they're always just trying basically to not die by suicide. Substance use disorders, again, is another form of self-injury. Kind of impulsive sexual behavior is very common. It's really critical that we work with families and support systems around borderline personality because, again, it's very easy to unwittingly reinforce this behavior, right? So, again, suicide attempt, calls the boyfriend feels incredibly guilty, he says, no, never mind, we can get back together. Now we've reinforced the behavior, right? And now she knows next time she can do the same thing. And unfortunately, at some point, it won't be 10 Lexapro pills, it'll be a whole bottle of Tylenol. We don't typically diagnose this in teens just because they're still developing and personalities can change over time, but we should be managing this as soon as we can. And again, that's dialectical behavioral therapy, it's medications for the symptoms, and it's trying to help people function better and stay safe. Another thing to mention in here, you saw there was the THC use, marijuana use in this patient. Substance-induced depression is rising rapidly. And again, as alcohol use disorder and other substance use disorders are growing, especially marijuana, given the legalization or decriminalization status in many states, this can independently cause depressive symptoms. So we think about, again, things like alcohol and marijuana being central nervous system depressants, so actually directly generating depressive symptoms. We think about things like cocaine or overusing amphetamines, even prescription ones like Adderall. Again, sort of the withdrawal period from those medications being essentially depression in and of themselves. Unfortunately, the way the brain reacts to being sort of robbed of those stimulants is to feel depressed. But again, medical steroids for autoimmune conditions or other illnesses. Again, chemotherapy agents are classic for this. Immunomodulators, and we always talk about when teens start Accutane for acne. That's a huge warning and to sign a waiver about suicide. just suffice to say that it's not just illicit substances, it's also sometimes prescription medications that can cause this. And again, we always ask about this at every psychiatric diagnostic assessment. And I'll make a comment here that may be more or less popular depending where I'm at any given time, but again, we think about, we live in the real world. As psychiatrists, of course, there are many situations where alcohol is an important social, kind of mediator, and it's something that brings people enjoyment and can bond people. The medical recommendation is to drink as little as possible, period. So this is no longer the one glass of red wine a night from the cardiologists. They have been overruled. You'll still hear them every once in a while. The antioxidant load of resveratrol and things like that in red wine does not overcome the central nervous system depressant effect, and so we recommend that people don't drink these. Okay. Last case here. Andy. So Andy's 65, gradually worsening depression over the past 5 years. Had a little bit of depression previously. And nothing that brought him to a psychiatrist, but he kind of looks back and says that, he did have some in the past, some periods. Again, initially during this period was doing fine, was functioning well enough, but he's starting to have these symptoms really impact his capacity to work and live. First thing he noticed was just subtle decline in mood. So again, some of those symptoms we saw in Mary earlier, but kind of in a less severe way, not so dramatic. But has also felt just a lot less sharp and more forgetful in the past few years. Retired a little bit earlier than expected in the last year due to symptoms kind of just, again, overcoming his ability to do the cognitive tasks in his accounting work. He has worked with a cardiologist who has really strongly recommended that he exercise and kind of take the other behavioral interventions we mentioned after he had a mini stroke. And he had some symptoms and went in, and they actually found on his brain scan a small area of stroke. So he's taken those recommendations, lost 25 pounds, and gained some physical strength by exercising with resistance training. He does have a history of Alzheimer's disease in his family. So another big category we always want to rule out, again, I mentioned this multiple times already, but sort of like substances, it's kind of checkpoint one, to make sure we're not missing something that would cause a depression, is depression due to medical issues. So what we will see in many people who are developing other conditions, especially neurocognitive conditions like Alzheimer's disease or Parkinson's disease, is that depression will be the first recognizable symptom. So in many people, especially Parkinson's is really, there's great research on this. For many people, when you go back, when they have Parkinson's disease down the line, you look back, the first sign was depression, almost universally. Following strokes, cerebrovascular accidents or other kind of, whether series of strokes, we call them TIAs, transient ischemic events. The rule for these is that people will feel depressed at some point. We had a little bit of that in the Andy, so it's a little bit of a mixed picture, right? Again, cardiovascular disease, metabolic disease in and of themselves can cause depressive symptoms. So especially if you're getting more severe cardiovascular disease, again, it's not abnormal for people to feel more depressed than they have in the past, especially if you get a little bit of history like he did. Even things like orthopedic injuries, again, like we discussed. Hypothyroidism, critical to rule out. This is why it's so important that we do a full physical, we look at the whole medical history, we try to figure out what all the risk factors are. And here, unfortunately, this is a patient who's in the early stages of Alzheimer's disease. And this is kind of a classic story. You just get this very gradual onset of depression and cognitive decline. But again, we can really do a lot to mitigate the risk. And one of the things that helps with the cardiovascular disease is in that nutrition and exercise approach, is actually a very potent way to reduce the onset of Alzheimer's disease and other cognitive diseases. So there's great evidence that if you pick up exercise and you reduce the inflammatory burden of poor nutrition and kind of add in good nutrition, you can really delay the onset of Alzheimer's disease. So anyone who has a family history, this is where you start, and early. On the topic of kind of general medical issues, I think we're getting more and more attention. There's more and more women's health specialists nowadays for especially mental health, but general health as well. We know now more about how shifts in ovarian hormones like progesterone and estrogen are linked to mood fluctuations, depression, in a very deep, kind of inextricable way. Again, often fluctuations in hormones will mimic those depressive symptoms again almost directly. You'll often see a little more irritability. So in some ways it almost looks more like how men often experience depression. And you'll have the hallmark physical symptoms. So whether it's any one of the versions we have below, you'll have kind of appropriate physical symptoms around what time in life that is. Premenstrual dysphoric disorder, again, this is something we'll see often in combination with major depressive disorder or other disorders. But the difference here is, again, it is hormonally based. It is technically a different thing that does not necessarily relate to your risk of major depression. Very classic, you will hear women say, especially if they track their symptoms over time, so we always give them a diary and a journal to track their symptoms relative to the period. If they have the symptoms start 5 or 7 days before, and then there's sort of this like miraculous recovery when they start their period, that is classic premenstrual dysphoric disorder. And again, the nice thing is we can kind of, number one, understand that differently, number two, treat it a little bit differently. Hormonal approaches, and then what we can do is actually give antidepressant medications for only part of the month for some people. For people that have major depression and PMDD, what we'll often do is increase the dose just before that period starts. I should say the period of depressive symptoms. Postpartum depression. So again, acute symptoms right after delivery. Now you get a significant decline in progesterone after delivery. This is again unrelated to major depressive disorder risk. This doesn't mean you're more likely or less likely to have depression over time. The nice thing is here, we've had a huge treatment advance in the last 5 or 10 years. IV and now oral medications are available that will basically correct those hormone levels and are basically curative. So again, for women that are suffering from this, again, it's so important to let your docs know. I mean, it's not fighting through 2, 3, 4 weeks of depressive symptoms after giving birth. And then finally, perimenopausal time is, again, another one where women will often experience depression, kind of, especially fatigue and sluggishness, the vasomotor symptoms that are so disabling for some people can be really depressing in and of themselves. One bright spot, though, is usually when women reach menopause, most mental health issues get better. So they can have kind of a flat spot to operate on after that. Bipolar episodes go down, depression episodes go down. It's sort of a period of stability. So one thing we always want to mention here, and again, we do speak quite a bit with faith populations too. This is not a comment about policy or kind of thought process from a religious standpoint. This is just about kind of protecting people who are vulnerable. We do know that people who have identified as LGBTQIA+ are at a significant increased rate of depression and suicide. It is many-fold times the rest of the population. What we try and teach, especially families who are struggling a little bit with a teen who's, sort of thinking through their identity or who has come out, often say, again, we're talking about respect. We're talking about, identifying people as, worthy of respect regardless of what they're bringing to the table. That includes, things like drug use and other kind of choices that people are making that, we don't necessarily agree with. I think, what we pitch as a mental health community is that it's possible to support people and no matter where they are without necessarily condoning anything they're doing. So, supporting someone, loving someone does not mean you have to agree with everything they do. For teens and young adults who are exploring their identity, I think unfortunately that the reaction that some families will have where they sort of ostracize and kind of, there's that critical response can unfortunately just add trauma and kind of anger and disconnection when a lot of these people need connection more than any other time in their life. So again, this is about honoring both faith and beliefs, but also just respecting people and really helping them when they need help the most. Suicide for those people is often marked by the time when their families kind of kick them out and can express lack of connection. Again, just kind of ending here, I always hate to end on a sour note, but we'll, or on a sad note, but we'll answer some questions as well. Suicide prevention, you cannot talk about depression without talking about suicide, and you've heard me talk about it quite a bit today. Part of the reason is to normalize this discussion. I think suicide feels like an incredibly rare thing, kind of an easy to stigmatize thing, but as you saw, the rates are incredibly high. The rates of suicidal thinking in adults can be up to 12-15% of the population experiencing some thoughts about suicide. So part of the reason we mention is we want to make it clear that many people will feel these, and that it doesn't necessarily mean that person is doing anything wrong, that Again, it's not a moral question as far as we're concerned. This is a symptom of depression. If you ever have concerns about safety for yourself or for a loved one, if it's a loved one or a family member, friend, please ask them about it. Please talk to them. Again, every talk will include this sentiment in the middle here. There is some misconception that if we talk about suicide to people, that we will kind of introduce the idea to them and they will start to think about suicide as an option. Study after study after study shows that it does not increase suicide risk, it starkly decreases suicide risk. So ask about it directly. If you're worried about, especially a young person who may not have access to mental health, or frankly anyone else that you're speaking with, and you're really concerned about them and you're having that thought back in your mind like, man, this seems kind of bad, please include a question about safety in there. Have you had any thoughts about hurting yourself or not wanting to be around anymore? Like, I know it's an odd question to ask, but I care about you, and that's why I'm asking. We know lots of people die of suicide just because, unfortunately, they've never had an opportunity to get help. Again, if anyone's in doubt, please get them to a professional. Please get yourself to a professional. We deal with this day in, day out. It is, not a situation where we will immediately send someone to the hospital. Again, most of our patients at Skyland Trail will experience suicidal thinking while they're with us, and we hospitalize almost none of them. If you need a resource, 988 is one to keep in your phone, or just remember. 988 is basically mental health 911, and it's not only for patients, so it's not just a resource for people that are in mental health crisis. It's also a resource for family members or support systems, so you can call them and they will walk you through how to have a conversation with someone who's struggling, or they will tell you what to do to access resources for suicide help. And again, American Foundation for Suicide Prevention and NAMI, National Alliance for Mental Illness, great resources for families who are going through this for more education and just, again, great support systems through those two groups. They do a lot in the community. With that, I'm happy to take questions.
You've obviously mentioned how important exercise is for proper health. Are there forms of exercise that are counterproductive in terms of causing inflammation or, issues like that?
I've never been asked that question before.
I mean, you don't get a body like this, just,
No,
no
the answer
work.
is absolutely. Be respectful of everybody here. Yeah, so when I was in residency, I was in Philadelphia, and we had this rash of people coming through the ER. And they were all coming in acute kidney failure, or other kind of had severe joint injuries and things like that. And you can time this back to 2015, 2016, CrossFit. So moderation is the key to everything in life, I think. Nothing against CrossFit. I think it's great when done the right way. But we had a lot of people who were, kind of overexerting themselves, not attending to injuries, not hydrating appropriately, and again, just generating massive levels of inflammation, breaking down muscle tissue in a way that was actually clogging their kidneys up and sending them into renal failure. We put someone on dialysis who was 25 years old and in great shape because they literally did back-to-back CrossFit workouts to prove a point and had to get a kidney transplant. Never exercised again. So it's like, so the answer is yes. I think marathon running can be a little concerning sometimes, and again, you should really want to pay attention. And again, the nice thing is with inflammation levels going up, you will feel it. Like, you will feel run down, you will feel inflamed, your skin will be red. I mean, all those sort of things we mentioned, the swelling and redness and warmth and pain, you will feel those generally. So I would say that especially, I'll talk to young people who work out a lot, but really, especially because it's gotten so much more popular in the whole population, it's like, if you're feeling rough and not feeling like you should work out that day, you should pay attention to that. Good interventions though too. Strength training is getting much more data over time. So not just doing cardio, but including some like weightlifting or calisthenics. But then again, these aren't huge doses that we need. It's 3 to 5 times a week, half an hour to an hour is plenty.
Could you talk a little bit about diet? There's a lot in the news right now about keto being, right? There's an article in the New York Times about keto being good for different types of mental illnesses.
Yeah. The answer is that if you look at all the data on diets and nutrition, what you'll find is that they all have relatively equal success, and that most of the benefit is mediated by calorie reduction. So total calorie intake over time is a healthy place to be for most people, especially if they're in a state of kind of overweight or obesity. The ketogenic diet is a bit unique. It changes your body's fundamental metabolism into one where you're using ketones rather than carbohydrates to fuel the brain and other organs. It has been evidence-based. It has been evidence-based treatment to treat severe refractory epileptic situations in kids, especially over time. It does seem to have some antidepressant, anti-anxiety effects as well. It may help with mitigating long-term cognitive decline, people with Alzheimer's disease and other neurocognitive issues. It is not for everybody, and it needs to be monitored very closely. So I think what I'm worried about is, number one, most people don't do it the right way. I mean, your carbohydrate intake has to be very low for a ketogenic diet to kind of kick in and take effect. Typically below 30 grams of carbohydrates a day, which for most people is half a meal. And carbs come everywhere, right? It's sort of like, vegetables and those things, they count, those are carbs. The other thing too is that, some people will have a negative reaction to a ketogenic diet, and it can actually create metabolic issues, so you always want to do this under supervision of a dietitian or a doc. But some evidence, I'm hopeful. I have put a couple patients on ketogenic diets almost as an elimination to sort of see if we can get them feeling a little better. The commonality between most of the diets that have shown long-term benefit, like the Mediterranean diet, is one you hear all the time, and that has great evidence. It's that you've got lots of healthy fats, very low kind of in refined carbohydrates and sugar especially. There is a comment in general that sugar seems to be quickly approaching tobacco as the most toxic substance in our kind of overall health picture in the United States. You don't want to villainize anything, but just suffice to say that keeping your sugar to a minimum, especially refined sugars, is important.
I had heard that Emory was doing some research where they could do a blood test or a DNA test to match people with depression. You've got a long list of antidepressants, drugs, then instead of just, let's try this, that didn't work, let's try this, that didn't work, and march on down this, that there was research where you could start to match people to drugs available.
Yeah. So kind of two lines of research here. One of them that we have established, and we'll use occasionally at Skyland Trail, is called pharmacogenetic testing. So we will take, there's commercialized products called Genomine or GeneSight. We use these. You take a sample, and usually saliva, and you send it in, and you can actually see how that individual will metabolize different medications. So unfortunately, this received, pharmacogenetic testing received sort of statement from the American Psychiatric Association that it was being overutilized probably 5 or 6 years ago now. We were using it for a lot of patients, and we were too. Again, it was helping. What we realized is that it's not helping as much as we thought it was. What it's used for is dosing. So it will take a list of medications, basically every commercially available medication, and it'll sort of, again, run the different liver enzyme systems that process those medications and see, if your liver specifically is more likely to metabolize that one quickly or that one slowly. That affects the bloodstream levels of that medication. So, for example, if it shows up that, Prozac is sort of under-metabolized by one's specific liver metabolism, and again, this is unrelated to general metabolism, this is a specific biochemical process in the liver. If it's under-metabolized, that means your blood levels are going to be increased because it's not being cleared as fast, and for that reason, we would just dose it lower. Unfortunately, what happened was people would look at these reports and they'd say, oh my God, I can't use Prozac if it's on the red list or something like that. We've had people come in, they've gone off their medications on their own because they received this test and said, why is my doctor's incompetent? Why are they having me on this meds on the red list? It's like, no, we would have done the same thing. So it's a little overutilized. But the second vein I'll just mention real quick, there is now testing too to actually look at biomarkers and see which medications might work more effectively. So that's a little higher level, not in use clinically yet.
To piggyback off that question, if somebody's in long-term treatment, like on Lexapro, 10 milligrams, and it starts not doing for them what it used to, and the doctor on the dosing for that particular medication is next is 20, will you all ever be able to tailor it exactly how much a person needs for their particular depression or anxiety, instead of just going from 10 to 20? Maybe they need a smaller amount, or
17.
Yeah.
Probably not predictively, if I had to guess. Certainly you don't know what you don't know at 2024, right? But my guess would be that at a certain point, we start to put together this information, and what we'll often do is, with someone who comes in that situation, we'll say, yeah, I know you're doing well, but my guess is we were just below the level we needed to keep you stable indefinitely. So let's do 20. Let's get you all the way to remission again, and then let's gradually peel back.
Okay.
So you kind of get to that same point without so much biomedical research, I think. Again, the sentiment we typically try to instill in patients is that if they are no longer responding to a medication, these meds don't just stop working. That's not a phenomenon medically. What is a phenomenon is that they were just slightly underdosed and that they had breakthrough symptoms. So we'll often try one higher dose. One bit of warning for antidepressant medications, there's a very unique kind of medical process called tachyphylaxis that happens with some people with antidepressant medications. And what that means is that they will be on, let's say 150 milligrams of Zoloft to treat depression and anxiety. They're doing great for a while, let's call it a couple of years. They start to, with their doc, reduce their dose to, 125, 100, and then at some point they have symptoms come back. Unfortunately, with some patients, and it's not the majority, but it's a significant proportion, going back to 150 will not get them the same response it got them previously. So this is why we're a little bit cautious, and we want to make sure that we give real adequate attention to stability over time before we start to reduce medications. The data shows you that if you wait, again, once you hit a point of remission, so again, very, very clinically stable, if you wait at least 6 months to a year, and we urge a year in most people, before you make any dose adjustments at all, like any reduction, not coming off, just reducing at all, that your likelihood of relapse goes down significantly. So we're telling patients basically like, just saddle up, because you got at least a year on this dose. And again, if they know that up front, it's not this, oh my gosh, I'm better, so can I stop it, kind of like an antibiotic. This is about, again, allowing the brain to recover. Again, going back to the inflammation slide, the brain has to sort of become non-inflamed over time. It has to start functioning as it did when you were, pre-depression. So a lot of times we'll give a little more time just to make sure that doesn't kind of kick back in. I know we're at time-wise. I'm happy to stick around and answer more questions, but I won't be offended at all if people leave. So.
Thank you so